As a medical oncologist, it's very nice to see a patient who's been diagnosed with cancer that is cured it appears, and has a very good prognosis and doesn't need any other further therapy. Otherwise, it's nice when you have a patient who has a cancer that's been curatively treated, but a patient has a relatively high risk of cancer coming back, and you can treat them with drugs to decrease that risk. Or even other patients in whom they have metastatic cancer that if you left things alone, the natural history would be the patient to die from that cancer, and yet you can treat them with chemotherapy and have a chance of curing them. However, there are other patients we see, many patients, who have cancer in whom cure is not a realistic goal. What do we do in that situation? This meeting about palliative care and supportive care has been very helpful for dealing with that particular issue, which is a very common issue in our patients. In that situation, it's important to be honest, and I call it compassionate honesty, to tell the truth in a compassionate manner. And when I have a patient where cure is not a realistic goal, I describe that to the patient and say that cure is not the realistic goal. And in that situation, what the heck is the goal for a patient in there? And the goal there, I go on to say, something I've been saying for decades, is to help a patient do as well as possible, for as long as possible. I then go on to say that I've really struggled with what the heck do I mean when I actually say that. In the last decade or so, I've decided I'm going to break it down into 4 sections that I, as a man and relatively concrete, as opposed to more abstract, can think about a bit better. And those 4 goals are: we want the patient to have the fewest side effects as possible from the cancer for as long as possible. 2, the fewest side effects as possible from the treatment. 3, the longest life. And 4, the best quality of life. And I can understand those things better. And the nice thing with that is that those goals do not change as the disease process changes. Initially on, it may be giving chemotherapy or other sorts of therapy, radiation therapy, surgery, hormonal therapy, to try to improve our chances of making those 4 things last. When it comes time, when the disease has progressed, and even to the point where it's time for hospice, the goals haven't changed one iota. They're still there. This meeting has been very nice in setting up how do we talk about patients, those things with patients, using palliative care physicians to help facilitate the oncologist to talk about those sorts of things. Those are some of the things that we think about when we think about palliative care and supportive care in our patients with cancer.